Hello, I'm Dr. Jim Rosso, the editor-in-chief of clinical dermatology at the Journal of Clinical and Aesthetic Dermatology, known affectionately as the JCAD. And there's been a lot that has gone on in 2024. It would be a very, very long video if we covered everything. And I tend to talk too much anyway, so that would make it even longer. But what did we learn in 2024? Well, we learned that there's a wide range of therapies that go beyond just the way we tend to pigeonhole therapy. So this is for a Th1 disease, or this is for a Th2 disease, or this is this cytokine, and this cytokine is the key cytokine, or for a certain disease state. Those things are partially true, but there's a lot of crossover. And that's why when we look at specifically, for example, some of the new non-steroidal topical agents, we have something like topical ruxolitinib, which is approved for vitiligo, being used over a prolonged period of time, and is also approved for atopic dermatitis, being a Janus kinase inhibitor, right? And because the Janus kinase enzymes affect a variety of different pathophysiologic pathways. And then it goes beyond that. We can see ruxolitinib being looked at for lichen planus and some other disease states. And so there's a spillover beyond just targeting drugs into a specific therapy because we target in our mind that this is what the drug does when a lot of these mechanisms spill over. That's also true of topical roflumilast, which is a phosphodiesterase 4 inhibitor, and topical tapinarof, which is an aryl hydrocarbon receptor agonist. These are intracellular enzymes in many, many cells, certainly diffusely present in the skin. And those intracellular um, receptors and enzymes can affect a variety of different pathways that can have influence on a variety of different disease states. That's why you're seeing reports, and in the JCAD, we have case reports in January 2025 and others coming, where being looked at for use in off-label treatments because these mechanisms are involved in a variety of different disease states. So we really have to have an open mind in that regard. We've had a few new agents, one targeting interleukin 31, nemolizumab, and interleukin 31 is a very important cytokine involved in itch, but affects other components, the skin barrier, um, you know, fibroblastic activity within the skin, inflammation, and hence nemolizumab, which is an inhibitor of IL-31. That's an important cytokine driving a variety of different diseases. We have FDA approval for prurigo nodularis, where it's a very effective agent, and also evaluation for atopic dermatitis, which we're expecting approval pretty soon. And then also the anti-IL-13 agents. We've had tralokinumab for a while. These are also injectable monoclonal antibodies, just like nemolizumab, but it's a reverse. It's not IL-31, it's IL-13. We've had tralokinumab approved in adolescents and adults for some time now, and now lebrikizumab, another anti-IL-13, more recently approved. Both of these, tralokinumab and lebrikizumab, are for atopic dermatitis in adolescents and adults. They inhibit IL-13, but they bind differently on that cytokine, and they have different patterns of some of their pharmacologic aspects, and you have to look at each of them in terms of what they're actually doing with their clinical data. They're both very effective for atopic dermatitis and have favorable safety profiles. Lebrikizumab has some very interesting data in terms of how long many of these patients maintain their efficacy after discontinuation, which I think is an interesting component that they're emphasizing because they had very good results in that regard. That can happen with tralokinumab and also with dupilumab, but the data we have is those prolonged maintenance of efficacy were not as long based on the studies that were done but they're not head-to-head comparisons. So these are things to look at. Each one has their own merit in terms of what they can deliver. Obviously, dupilumab inhibits IL-4 and IL-13, and it's approved for atopic dermatitis down to 6 months of age, and also has approval for other atopic diseases. So look at each of these drugs independently. And remember, if a patient does have some difficulty, let's say a conjunctivitis on dupilumab, which they can have from atopic dermatitis very often, the disease in and of itself, but they're having difficulty on dupilumab, if they're switched to an anti-IL-13 agent, and we have a fair amount of this data with tralokinumab, but also some with lebrikizumab, they can have efficacy without the conjunctivitis when they're using the anti-IL-13 alone. So keep an open mind. In terms of switching, there's also the option of going to a Janus kinase inhibitor, which may improve the efficacy over and above the biologic agents based on the data, but will carry the evaluation with the laboratory testing that's required, which the biologics do not have. Also, bimekizumab. We've gotten hit with a lot of new information on bimekizumab, which is an anti-IL-17A and anti-IL-17F, as opposed to, for example, secukinumab and ixtekizumab that are anti-IL-17A. All of these approved for moderate to severe psoriasis in patients warranting systemic therapy. So bimekizumab has been approved for those patients by the FDA also, and actually shows the quickest and superior results in terms of managing of the psoriasis, but carries a greater risk of patients developing oral candidiasis, which is typically easily managed, but it's something that we have to be aware of. But there have been two recent approvals beyond the plaque psoriasis, moderate to severe plaque psoriasis. There's psoriatic arthritis, active psoriatic arthritis, which is a lower dose than the psoriasis dose, unless the patient happens to have the moderate to severe plaque psoriasis and psoriatic arthritis. You would use the higher dosing that's directed for the moderate to severe plaque psoriasis. Otherwise, you're utilizing a lower dose, 160 milligrams every 4 weeks for the uh, psoriatic arthritis. And recognize you can have patients with psoriatic arthritis that have they're mild. They have maybe 3 or 4% body surface area that can often be controlled by that lower dose for the psoriatic arthritis. Controlling that 40% body surface area of psoriasis will often occur. So you have to look at the dosing for what that primary indication is you're treating, but you may capture psoriatic arthritis also in some of these patients. It's also approved for ankylosing spondylitis, active ankylosing spondylitis, and also some of the axial skeleton spondyloarthropathies, which in dermatology, we can sometimes pick up psoriatic arthritis because the patient has joint stiffening, or maybe you'll see some swelling, or they have dactylitis or enthesitis. We will sometimes be the ones that pick that up very often because they're in our office for psoriasis, and we can save them a lot of morbidity by getting them treatment for the psoriatic arthritis early. But the axial skeleton disease, which is often back pain, who doesn't have back pain if you ask them? But these are going to be patients often younger, often below the age of 40, though they can be older, can affect women, though they often will say that it's men. About a third of the patients can be females, and they're often younger patients that have back pain that's just somewhat more out of the step of what you might expect, especially someone that doesn't have a job where they're exerting themselves and getting a lot of mechanical back pain. But a tip off with these patients is that with mechanical back pain, which a lot of us will have from bad posture or lifting, or some of my friends that run all the time, they have more problems than I have with their joints and their back anyway. Um, you know, people will tend to need to rest to feel better for their mechanical back pain. Patients that have inflammatory back pain from an axial, um, arth- you know, spondyloarthropathy type of condition, they move around and their back pain gets better. So it's very similar to the psoriatic arthritis, where when you're at rest, you tend to get stiff or more painful, but then when you're moving around, you get better. So that may be a tip off to those patients. And they're also treated on the lower dose once a month. But now we have approval for hidradenitis suppurativa with bimekizumab. We've had it for a while with secukinumab, which is an anti-IL-17A agent, very effective. And I think the anti-IL-17A agents are an improvement over the TNF agents uh, for like the adalimumab for hidradenitis suppurativa. Bimekizumab has some excellent data. They've looked at some higher bars of improvement for hidradenitis suppurativa, and it's a higher dose used more frequently than even for psoriasis. And that's pretty standard with hidradenitis suppurativa, a complex pathophysiology, deep disease, patients that can get, you know, permanent sequelae like scarring and sinus tracts and draining fistulas. Uh, it needs more frequent use at a higher dose. And I think it's really important to integrate it as early as possible to really shut down this particular disease. A couple of new therapies. There is a low dose oral minocycline, which is an extended release minocycline that's different than the extended release minocycline that is FDA approved for acne, right? That we've had. This is a different formulation that is approved for papulopustular rosacea in adults, patients presenting with papules and pustules and perilesional erythema. The low dose minocycline, which is formulated for once daily use and has a spectrum of releasing more slowly, geared to rosacea treatment, shown to be very effective to reducing papules and pustules and the erythema surrounding papules and pustules. That is now FDA approved. And one more that I don't think we think about enough is primary axillary hyperhidrosis. We've obviously had an agent, a wipe agent that has been approved for that and has been available for some time that when applied has anticholinergic effect and can reduce the sweating of axillary hyperhidrosis very effectively. That does require being touched by the hands. So you have to be careful if you're rubbing your eyes so you don't get some of the ocular changes that you might have, uh, pupillary changes, and maybe blurred vision. There's another agent, soft peronium topical gel, 12.45%, that is FDA approved for primary axillary hyperhidrosis. A little bit different mechanistically. It does target what's called the muscarinic 3 receptors that are more directed to the eccrine sweat glands than other agents do, like glycopyrrolate type agents that are not as specific for the M3 receptor, but can inhibit at the M3 receptor. But one of the things that's different about this agent, and it is shown to be effective for primary axillary hyperhidrosis, is there's no touching of the actual formulation itself. It's delivered in a way with its delivery device is a roll-on, but it's actually put on the top. There's a device where it's put on the top so the patient never touches it. That's applied directly to both axillae, and then that's covered. So there's no touching of the product, so no concern about accidental transfer. And you'll be hearing more about this. It's been FDA approved for a while, and it should be coming to the marketplace very, very soon. In fact, I think it may already be available. So that's a summary of just a few things that there's so much more, but I'm tired of listening to Jim Del Rosso right now, and I'm sure you might be too. So we'll sign off right now, and I hope this helps you with JCAD, some of my observations. Thank you very much.